Well, Africans spend billions of dollars every year traveling across countries in search of good health. The pursuit of wellness leaves many Africans behind, as only few people can afford the expensive nature of quality healthcare. Terminal diseases have ripped many apart and emptied their pockets as the continent's ailing healthcare struggles to make many heal. Now, the result is losing money to the rest of the world through medical tourism, while quality healthcare is most importantly an unarguable necessity. The world says it can champion economic prosperity. Welcome to VSA. I'm Sulaiman. Nations of the world are faced with great economic challenges, some of which their resources cannot solve. Where their resources don't suffice for their advancement, they look on to their environment. Now, the beautiful natural feel of their immediate societies become attractive, and they find business in hosting the rest of the world. They step it up when these same countries provide a healthcare system that can reasonably and adequately hold the demands of medical advancements. Such countries begin to earn from the big pot of medical tourism. Today in sub-Saharan Africa, South Africa has shown and proven it's a possibility and channel for prosperity. Now, the rest of the continent needs a rude awakening so as to are keen to the growth of such health sector for business and for life. Now, joining me now is Dr. Ganiu Jamiu. He's a member Association of Public Health Physicians of Nigeria, and Dr. Gbenga Alabi, Clinical Fellow, Neurology and Medicine at SHSCT UK. Gentlemen, good to have you both on Village Square Africa.
Good evening.
Well, anyway, the conversation has been a pretty long one here, and we're hoping to stretch it with both of you weighing in. Let me start with you, Gbenga. When you actually look at the ailments that take Africans abroad, we see many of them are problems of oncology, cardiology, and even internal problems in general. Other than the inadequacies of the medical system, are there enough specialists in Africa?
Yeah, thank you for having me, Suleiman. I'll say almost all over the world, there is paucity of specialists. So it's not only in Africa, it's just that we may have it worse in Africa. So that's that. And I agree to the fact that most of the individuals that sought help more probably oncologists, cardiologists, and some other specialties. But the unfortunate thing is we have some of those specialties in Nigeria and they can be solved. But some people still just feel maybe they need to get to UK, US, or Canada where they feel they can get help. But that's not always the case, actually.
Okay, let me bring in Ganiu here. Just recently, we've seen how much of improvement South Africa has, brought into the health sector, making it a big example of what should be. That's quite an impressive one for South Africa. What do you think is being done in that country that every other country on the continent should, look into and key in?
Okay, let me just say broadly that the basic thing to, have a very reliable health system is to have the manpower, competent, skilled manpower, well-trained, for which, to the glory of God, we are blessed with it in this country. Another thing is to have basic infrastructure and proper funding of that system. Unfortunately, if you look at our own country, it is so-so. In some places, we have the infrastructure, but in some places, they are obsolete. So, the world is a global village. There'll be a lot of advancements. So we need to also move in line with that in terms of infrastructural upgrading and so on, so that we can be at par with the international level. These are some of the common things we are lacking. And apart from that, funding, if you look at the ed budgets, it has not been encouraging. For the past 4 or 5 years, it has been below 10%, in the range of 7, 8, 9%. And I think that has been a major challenge. And even our insurance, national health insurance, the coverage has not been relatively encouraging. Just of recent, the new boss is trying to, see what he can do to get more people into the system. So that has been a major challenge as regards to the health system. And I think that have really relatively affected what we are seeing as regards to the medical tourism, where because people, based on this, people have actually lost confidence in the system. People don't really believe, again, that they can get the quality and the kind of care they deserve in the country on which they are present. Thank you.
Gbenga, I still want to rest, in South Africa and, try to make sense of what progress we have seen on the continent in South Africa, knowing full well that South Africa, isn't amongst the oldest in terms of independence, knowing full well that they went through apartheid. Now, are there things that we're missing that may likely be brought to the fore at the moment in terms of health? Because when we also speak about medical tourism, South Africa is also leading in that direction, to the extent that some people around the continent have had to also move into South Africa, while some who, by virtue of not having the resources in Europe, have also looked towards South Africa.
I agree with my co-panelist about what he discussed. I think one of the major problems with medical tourism is the belief that you are going to get better care outside your geographical enclave. And why this is so is because of the supposed rot that we believe we have in the system, poor funding, as my colleague has said. And I tell people something jokingly that anywhere in the world, healthcare cannot be free. Somebody has to pay for it. And why we are having that problem in the country, in Nigeria, it's that most of our healthcare financing come from out-of-pocket payments. And that makes little funds available to carry out and to carry out care, and also even in research. And that's one. And secondly is my colleague also, I also agree with the poor funding of the healthcare system. We see that in the UK, in the US, when elections are coming, or even year in, year out, we see them discuss funding of the NHS in the UK, Obamacare, Medicare, Medicaid in the US, and the likes. They form cardinal issues that are debated by the politicians. But in Nigeria, we see that nobody gives damn to some of all those things. And all this would ensure that the healthcare system continue to be on the downward trend. And for people who feel they have the ability to pay, they would rather just want to go out rather than just stay in and get care in some other, in the available centers. I like the introduction. We lose so much amount of money to sourcing for healthcare in the outside world. I looked through the website and I saw Nigeria is losing close to $1 billion US annually to medical tourism. So this is huge, and there's need for us to cut that. And funding still remains a problem that must be addressed. And this cannot be addressed if we don't look for how do they get those funds. And I've highlighted some of them in my opening statement.
Let me bring in Ganiu here. Ganiu, you heard Gbenga, and he's spot on, knowing full well that when it comes to electioneering campaigns in the Western world, health is always a major, talking point. as we've seen over the years. But in Africa, we haven't actually seen pretty much of that. How can the people, of the continent begin to redirect the focus of, such campaigns towards an important sector as health?
I think, there is a different, that's why we have what you call third world country, developing country compared to developed country. The priority of individual here, let's be very realistic, is how do they, get food? How do they survive on a daily basis? So when somebody is hungry, do you think we think about health? So these are some of the things when it comes to during election period. People want to see issue of, our challenge is quite different from other countries. Are we talking about issue of unemployment? Are we talking about people that don't have what to eat and so on? So these are some of the things that the people prioritize. So I think, not that the health is very key, but people don't remember that at the first time. They remember what they will eat, how would they survive, talk about issue of unemployment and so on. And those are some of the things. It's only when somebody has one health challenge or the other, that is when the issue of, going to the health facility, it become an issue. And apart from that, there's a general poverty in the land. And that is why you see in some countries where people paid, they have money to pay. In Nigeria, majority of places you find that there is free maternal and child health, there is a lot of free, healthcare service at both at primary healthcare level and in some places at secondary healthcare level, because some people cannot even afford it. So those are some of the issues we are talking about. Our priority on individual level varies, but I think it's very key if actually we can actually put our health system in order. It is not that people have not been talking, but it's just that maybe we need to continue to advocate for it, that we need for better funding, for better healthcare, infrastructural upgrading, and so on. And you can see part of the reason why the resident doctors are on strike is still part of what we are talking about. So I think that's just my taking as regards to this.
Gbenga Alabi, I'll bring you back to this. We still have not been able to put our finger on how we can make, the issue of health a top priority. Listening to Ganiu, he said, amongst every other thing, the people still don't understand that health is key. They'll rather talk about, infrastructural, deficit like, roads, power, and the likes, forgetting that it is only a healthy man or woman who will ultimately enjoy such, good of democracy. So how can experts like yourselves weigh in when it comes to such moments of politics and, manifestos?
Yeah, thank you. According to the Maslow stages of need, I quite agree with my senior colleague. He said basically food and shelter lies number one. But I agree with the fact that it is only someone who is healthy that can actually enjoy those infrastructures. And for all you care, those infrastructures to contribute to good health well-being. So it looks like what looks like a vicious cycle of poor infrastructural facility will result in poor healthcare delivery. Now, I must say something here that for us to get it right, I think one, our primary healthcare system must be revitalized. What Olikoye Ransom Kuti, the idea he had when he brought the concept of primary healthcare needs to be reviewed, and we need to strengthen that system. Because if we actually have a functional primary healthcare, I feel that the burden of healthcare delivery in the country would improve. I must tell you that in developed countries, you see that people don't just go to the hospital. You just when you have a problem or a challenge regarding your health, you ring your doctor or the GP, and the GP will see if they can get it sorted at the local practice. The GPs are the GPs are like our primary health care. But you see that in Nigeria, we don't even have doctors in our primary health care facilities. The only state I can boast of say, okay, they've got doctors in the facilities is, I think, Lagos State. They've got some doctors that take calls in their primary health care facilities. Other states, I come from Ogun State, and I can say that we don't have one. Probably in the local government, we have just one doctor supervising about 20, 30 healthcare, primary health care within its local government. They call them the medical officer of health or so. Now, that is not something that is normal. But if we strengthen our healthcare system, I think we have a better outcome as to what our secondary facility can then face what they are meant to do, and our tertiary facilities will not just be treating malaria, but will be faced with what they are meant to cater for. And this is, we can actually start the reorientation now. We've got like 2 years to the election. I agree food is important for us to discuss. Electricity is important for us to discuss. But our health care delivery is also important for us to discuss. Not all of us can travel to the developed countries to get healthcare service. And for all you care, even when you have money in Nigeria, you are just one diagnosis away from poverty. That's one thing we should know. Because provided we still have out-of-pocket delivery, I don't think we are going places.
Well, I think that's a sad one, but again, it's why we're here, why we're having this conversation. Let me bring in Ganiu. There are many private institutions in Africa, and of course, at the moment, out-of-pocket payment is quite high in the absence of good health insurance policies, as highlighted by both of you. So, does the medical system of the continent need an overhaul to helping, key into such, policies as we've seen in Europe and other parts of the world?
Okay, thank you very much. I want to say that we have such policy even in Nigeria. That is why we are actually copying some of those good ideologies from Europe and America. And for instance, the National Health Insurance Scheme was born out of the NHS. And it's just that we started, we are very good in having a very robust policy document. But when it comes to implementation, that's where the challenge is. The challenge we're having with the NHS would have been a fantastic approach to a kind of solving some of these challenge. Unfortunately, the coverage only restricted to the public sector without taking, the coverage only affect the public sector and leaving the private sector. So at this moment that there is a lot of reform, I don't know how far they've gone. That would have been a good opportunity for us to actually, achieve some of issue of reducing catastrophic spending, out-of-pocket spending, and trying to ensure that we have a pool in terms of medical expenses. But we're having challenge with that. But if you look at the document, it's so fantastic that if it is properly implemented, we can solve some of these challenges we are talking about. As part of that, again, I remember there's what you call Basic Health Provision Fund, a Basic Health Care Provision Fund, which was also part of the intervention to see that we take care of the vulnerables, those in terms of basic health care. It still is a kind of an amount that is being allocated from 1% of annual revenue from the government. It is meant to actually key into the insurance scheme, and as well, it also even cover emergency situations. But as I've said, we have some document on ground, but the level of implementation is still what we are still having challenge in regards to that. If not, we have all these documents on ground. But it's just that the implementation and how can you expect an effective implementation when the overall budget of the health, which I remember there was a meeting in as far back 15, 20, 2 decades ago, that about 15% of annual budget should be set aside for health. That was the recommendation for the African Union. But as I speak to you, in the last close to a decade now, the annual budget has been in the range of 7 to 8%. So these are some of the challenges which I think the only way we can do is to continue to advocate to the government, because it's really a big problem. Not that we don't have such policy documents on ground. Thank you.
Well, I'm excited. He's just, Ganiu, you just raised a very important one there, a reminder of the Abuja Declaration, by the AU, which hasn't actually come to fruition at the moment. Now, Gbenga, would, living by example from the, political leaders on the continent, would that have helped, activate that Abuja Declaration, which nothing has been done at the moment? Now we're talking about African leaders, seeking medical, services within the continent or even in their home countries.
I'll answer that. I'll make a proposition first. One is that having to travel out of the country to seek health care is not corruption if you have the money. But having to have the money being paid through the national fund, it's not fair. That's one. And two is that it is unethical, or I'll say it is immoral for you to leave your people and go to where they have better health care. Because if you are coming to the NHS to seek health, and if they don't develop theirs, it becomes, where will you go to? Let me give you an instance. If Boris Johnson now leaves UK to come to Nigeria to seek help, it looks not normal. And it is unethical, because it means that that UK have not got a good healthcare facility, but now probably Nigeria has, and that's why you're coming. So it is unethical for the political office holders to have done that, but it is not that it is something not normal. That's one. And I think this country, is it Tanzania? They just lost their president. I'm not sure. I think he signed a declaration recently that political office holders should not leave the country to seek healthcare. And I think he died in the country. I'm not very sure of that. But if he had died in his country and he never sought help outside, I think he's just trying to be moral and to justify the fact that even me, myself, as the president of the nation, I'm not going to leave out. I'm going to stay and seek the same healthcare facility that is available for the common man on the streets. And if we have a very well-developed healthcare system, I don't think well-to-do individuals in the community would have the cost to leave their primary country and go spend the taxpayers' money in another man's country. I don't think that would have occurred. And my co-panelist, Daniel, said something about NHIS. It's a fantastic model. I remember in medical school, the public health physician, and when we were doing community medicine, we read about the model, very nice model. But you see that what is the coverage of that NHS or NHIS? That coverage is less than 5% of the Nigerian population. And he even said that it's those in the public sector. I must even say that it is not even all those in the public sector. I've worked with a state government hospital in Nigeria, and I can say that when I was working there, I was not covered by the NHIS. And that's a state, because the states are not even within the NHIS. And these are places where they can pool funds. Because if the three of us are on this panel now, let's say we pay 5,000 naira monthly for healthcare. And if the three of us over 1 month, we never got sick, we have 15,000 naira to spend to someone who has fallen sick, which is something very good. And that's what they do in the NHS. They pull funds together and to take care of the sick. And that's what making the system continue to grow until we pull those funds and ensure that we expand the coverage of the NHS. And also, when we now have those funds available, we should now ensure that we don't have corruption within the system where the funds are siphoned to other unauthorized pockets. And we can only do that if we continue to review and audit our system regularly. And that is what the developed worlds do, and that's why they have a better system.
Let me go to Ganiyu here. Listen to both of you. You realize that the fears are enormous. Unlimited. Now you have, better situated this issue. And again, your other fear is that even if we have a pool where that, resources or that money should go into, there's also the fear of someone not bolting away with that. Now, Ganiyu, what readily comes to mind is the kind of system that Africans, especially the ordinary African who is not wealthy enough to jet out of the continent to seeking medical attention. How can, the National Health Insurance capture such, individuals? Now we're talking about your country, Nigeria. How can that work and, give some form of trust, in the system?
Well, as I said earlier, the coverage has been low. But of recent, we just have a new airship there, and he's trying to, develop a kind of different reforms, and they're trying to see how he can actually work with the private sector to see how they can capture other citizens who are not working with the government facility. I think that is ongoing. And apart from that, there have been a kind of such institution at the state level, like in Lagos State now, the Lagos State Health Insurance scheme, of which they are looking at those retirees and those that are still working. So I think there have been a lot of effort just to see that they capture those that are currently working and those that are, even the elderly. There'll be a lot of effort to do that. But my worry is that apart from the pool, my concern is the infrastructure. My concern is the funding. My concern is the, just like my colleague said, if not in Lagos State, that you can see doctors at the primary healthcare center. If you should go up to other parts of the country, like in the northern part, you can hardly see a medical doctor at the PSC level. So these are the human resources. These are some of the challenge. So in some places, you don't even see qualified health workers. So it's really worrisome. And I think it's so unfortunate. We have all the structure to see that we put things in order, but I don't know what's happening. Like we on a yearly basis, that usually the National Health Council, where all the commissioner and the minister meet to deliberate on that. So these are a lot of, I don't really know what is happening, but I think we should keep on praying. The implementation has been the issue, not that there are no structure, not that there are no policy, but I just think we keep on encouraging people. But one other thing I want to say is that apart from the National Health Insurance Scheme, we still have the private sector developed, which is still also running, and I think they are doing very well. It's just that how can we interface all the schemes together so that they can be more effective? That is my challenge. But I believe maybe with the new airship at the National Health Insurance Scheme in Abuja, maybe some.
Well, let's take a moment. When we come back, we'll see how much of activities that nations across the continent must look into. And of course, for Dr. Ganiyu, he's talking about prayers, and his fears are germane, just as that of Gbenga. But that's when we'll return. We'll see how much of solutions we can actually put to this and stop this journey of seeking medical services outside the continent. if you just joined us, you're welcome. You're watching VSA here on News Central Television, Lagos, Nigeria. And we're looking at medical tourism, understanding how best the continent can get out of this quagmire of its leaders, especially political leaders, going out of the continent seeking medical services. You know, putting a stop to medical tourism was a part of President Muhammadu Buhari's many medical promises to Nigerians. But in almost 6 years as president, he's traveled abroad at least 5 times for medical checkups. At the moment, he's outside. He's in the UK. And, you know, like President Buhari, many other African leaders are content with traveling abroad for health reasons, exposing the security architecture of their country to foreign influence. Africans have called for a legislative intervention to stop their leaders from leaving their countries in search of healthcare. How far that can go, only time will tell. But again, the good thing is that we have experts from across the continent. They've all been speaking on how to, redirect this trend. And I still have Gbenga Alabi, who is a clinical fellow, neurology and medicine in the UK. Thank you for your time, Gbenga. Quickly, let me bring in this, and I think this will resonate with you. India, you know, for some time now, has been an attractive medical destination. And part of this is down to their traditional medicine too. So is Africa's traditional medicine, I know, you know, when it comes to traditional medicine, some experts like yourself, I said to smile, you try to run away from this. Perhaps I should have had someone who is a traditional medicine practitioner. But can it be a global force? Is it sellable? Is this something you think the continent can sell?
Yeah, so that one, jokingly, even as a medical practitioner in Nigeria, and the alternative medicine, we are both regulated by the same MDCN. So that's why I just smiled. So it's not that they are just something. But I think that I quite agree that India, China, they've had to push some of their traditional medicine, and they had results with it. And this is because we allowed that system to be opened up to researchers. So if I've got probably a treatment for, say, malaria now, using traditional herbs, and I get it open to treatment, show the experts, this is the composition, let it go through NAFDAC, let them do the review, the clinical trials to pass through all the phases. If it's fine, I think, and they look at the dose, if it has any effect on the adverse effect on the body. If it's fine, they let it go. And it's not everyone that would continue to take tablets and the like. Some may go through alternative medicine, provided they get care. Why the orthodox person tries to shy away from alternative therapy is just because we don't have the dose that is lethal and the dose that is therapeutic enough. We don't have that. And until we have those things in place, then that is when we can say, this concoction is certified okay to be consumed by the populace. Because be that as you like, whatever you like, you can think of, the system has institutions in place to actually look at any form of therapy that is to be introduced.
You know, Dr. Gbenga, I don't mean to put you on the spotlight. The moment you use the word concoction, what readily comes to mind is that, well, your colleagues would use such, to qualify the traditional medicine mixture. For yours, it's a mixture. For theirs is a concoction. But let's leave that for another day and come back to, looking at that country, which is one of the, biggest destination for many Africans, especially the wealthy and the well-to-do Africans, India. What are those things, as an expert, you have observed in India that is making it, an attractive destination for people in Africa to move seeking medical, attention?
Yeah, thank you. When you say medical tourism, it means an individual having to move out of its primary location to another location where he or she feels healthcare is better. In traditional terms, it's just like people moving from developing countries to developed countries. But don't be surprised that people even move from developed countries to other developed countries if they feel that the healthcare delivery in where they are going to is cheaper. So we have to look at that. That's another form of medical tourism. So it's not only moving from probably developing to developed. And that's one. And two is that the Indian system is a model that I so much love. I think I've read a paper about what they did, and that's that the government ensured they developed the healthcare system by sending some of their citizens outside the country to learn from the developed world, and they came back and then built that system. That's something that is key. And if probably I've moved to a developed country to get knowledge, and what are the things that can make me come back to my primary country to ensure I bring in my expertise to develop my primary country? That means that I must be sure that where I'm going to have a system where I have most of the infrastructures that I need to work as a specialist. That's one. Then two is that the people must be ready to pay. And people being ready to pay does not mean that it has to come from out of the pockets. People being ready to pay means that there is a system in place that ensures that the treatment that has been sought are actually paid for, either by pulling from the health insurance system, which is a very good system. That's two. And thirdly, is that the political will of our leaders is also very, very important. Because if there is no political will, all these things will not come to pass. Even if you have returned, you may be frustrated out of the business. Even in the UK here, you see that there are private hospitals, there are private labs, as big as the NHS is, as very functional as it is. Some people still sought private care some people still request for tests to be done in private facilities, but that's their wish. It's nobody. You just tell them that okay, the system can do it for you, but if you want it faster, you can seek in some other things. And if the patient agrees, they get it done. Because we must say healthcare delivery is an expensive business, and somebody somewhere must pay for it.
Now, talking about payment for these, we have three levels in most parts of the continent. Let's look at Nigeria, for instance. That's the primary, the secondary, and the tertiary. And once upon a time, a health minister in Nigeria, Professor Ransom Kuti, made, an attempt to see how the primary health care can be, revamped. How much of, success did that, give Nigeria and perhaps maybe some other African countries?
Yeah, down memory lane, I think while in medical school, the primary healthcare system that was developed by Ransom Kuti was actually used as a model for other African countries. We must realize that one, most of the healthcare need of the Nigerian populace can actually be catered for by the primary healthcare. Do you want to talk of chronic health diseases, hypertension, diabetes, except when they become probably you are not having good control. That's when you are expected to send them to probably somewhere higher. And do you want to talk of treating malaria, oral diarrhea, and some other conditions? Those things can actually be catered for using a very good model that was being set up. But due to poor funding and poor remuneration on the part of the healthcare worker, the system broke down. And that's the breaking down of the system is what has resulted in where we are today. Let me give you a practical instance. When I was in medical school, in final year, we are expected to do what we call rural posting. And in the rural posting, I've had to spend like a month in a primary health care center in Ogun State. And when I was there, before we got to that center, we were told when we did our preliminary analysis and community entry that people don't actually patronize the health center because they felt that there are not enough hands to take care of them. And in a week, we can have just less than 9 people coming to seek health care. And I must tell you that within 1 week that myself and my colleagues got to the healthcare facility, we had close to 130 patients coming into that facility to seek care.
In just a week?
In just a week. And when we had that, we had supervision from our registrars then, and also the medical officer of health for that local government. The IGR of that primary healthcare center increased drastically. And that's a very good model that can actually be used. But if we have qualified doctors, nurses, and other paramedics to work at the healthcare facilities, I believe that the inhabitants around that area would look for healthcare and sought healthcare in those facilities. But because you know that if you get there, you may not find a doctor, a qualified nurse, you just, why should I go there? And that's why that system, a very good model, needs to be revamped. And if we can revamp that, even the queuing that we have in our general hospitals, in our teaching hospitals, will fall gradually. I must tell you that in the UK, except it's an emergency, you can't go there straight. So if I've got probably sore throat and the likes, I don't need to go to the hospital for that. I can just go to my GP surgery and I get sorted. But if they cannot get that, then they escalate it to the higher facility. And that's how it is. And that's the ideal model that was developed. But because of absence of manpower, I say absence because you'll be surprised that if you go to the health center in some states, you will not even find a healthcare worker. You won't even find a community health extension worker in some places. They have been locked and I don't know where their keys are. But if we have qualified personnel in those facilities, healthcare becomes even cheaper because we have drugs there that are labeled. Anti-malarials, some antibiotics, anti-diarrhea, ORS. These are common diseases that can kill the common man if not intervened early enough. And those things can actually be cared for at those primary facilities. And they don't even need to go to general hospital or having even to go to teaching hospitals. That's...
You know, let's try and make sense of where the keys are to those medical facilities that have been, you know, under lock. And I'm sure that you have some of your colleagues still on the continent here in Africa who's, you know, some of them must have actually reached out to you asking how easy they can also move out of the continent to be just like you in the UK. Now, we're looking at brain drain, which has actually been one of the biggest, you know, challenges, facing the continent's healthcare. How can the continent change, you know, this brain drain to what we can call brain gain? Is Africa ready?
Yeah, that's a big question. Is Africa ready? And I must say that even the plan to move or not to move is even all over the internet now. You don't even need anybody to put you through. That's on a lighter note. But the great question is Africa ready? I'll say I'm not sure we are. Because if we were to be ready to have that brain gain, then the strike of the Association of Resident Doctors will not have come up. And our political leaders will be accountable. And this is not only the political office holder, even the civil service that care, that look into healthcare policy formulation, healthcare financing, they should be held accountable. Because if all these people are held accountable, I don't think this strike can actually be averted. And is Africa ready? I'll say I don't think we are. We are not ready because
sorry to butt in there. There must be some indexes, some signs that has actually informed your answer to that question. Perhaps as we draw to a close, can you share some of those things that you have seen that has made you say, no, Africa isn't ready?
Yeah, one is every 4 in 5 doctors in Nigeria have the intention to move. That's one. Every 3 in 5 of doctors in Nigeria have already started the plan to move. Not only doctors, nurses, and even all other healthcare workers. Everyone has it in mind, or even they've even started the journey. You see people, even from medical, from house job, they've had to start writing foreign exams. That tells you that they are not even planning to even have a single additional day to be spent on the soil of Africa or on the soil of Nigeria. And that's because they feel that the future does not look bright in the African continent. And that's why they are trying to move to where they feel that healthcare delivery and job satisfaction becomes important. And it's not far-fetched. One, if you are not happy with your job, if you are not satisfied with what you are doing, Sulaiman, I must say that you want to move to go to where you'll be satisfied. When I was a medical student, I was joking with my colleague today that we read so many things in the textbook, and imagine having to practice what you have read. Look at the joy that comes to you when you say, okay, I need to request for this, request for this, and you get it done within 1-2 days. You are happy. And those are the things that are not available in the country, and that's why people still have it in mind to move. I've not even started talking about the remuneration of the healthcare worker itself. Just today, I was watching an interview granted by one of the leaders of NAD on YouTube, and he said that a doctor having to beg an hospital because he is unable to pay for the cesarean section of his wife. You can see how bad it is. And this is because if he's got enough money, he does not have to beg, get it done, and pay whoever has done the service. But because it's not hard enough, and I said it again, you are just one diagnosis away from poverty if you are in the country. And that's why most people, you are living because of sanity, you are living because you want to practice what you have read, you are living because you want to practice what you know, and not only because of money. Thank you.
You know, and the other aspect is having, left the continent, the leaders chase these brains outside the continent, seeking them. So let's close on this. Some of your colleagues have actually advocated a system where by African political leaders must be compelled by legislation to utilize same medical facilities in their home country. Do you subscribe to that?
Yeah, I think it is morally and ethically right to ensure you seek help and you seek your healthcare needs within the system that you govern. I think it's just the moral thing to do. It's just morality. And if you know that if I've got to be sick, I need to fall on this bed, then I think I'll need to prepare for that day when I get sick to ensure that things are working. I cracked this joke jokingly. I cracked this joke that, is it possible for the CMDs of an hospital to say, okay, if I fall sick, I think I can be nursed and cared for in this facility that I'm the CMD. If all our CMDs can do that, then I think we are moving closer to where we should be. And if all our leaders, both the legislatures, the judiciaries, the civil servants, and the common man on the street will seek help and seek their healthcare provision in the facilities that are within the country, I think that's just the normal thing to do. But it is normally right, and it is ethically right to just do that. But there is the freedom of movement. You can seek help wherever you feel. But if you have put yourself up to lead the country, I don't think it is right for you to leave the country and seek help. Okay, sorry, they said he just went for not seeking help, but he just came for checkup. So I don't think it's right for you to come for
well, I think it's a fine place for us to leave it, even though it leaves a sour taste in the mouth. You know, listening to you and your colleagues, you know, brings pain to a lot of Africans, especially those who are not wealthy enough to replicate the kind of attitude and culture of moving abroad for medical, services like the presidents of such countries or leaders. We'd like to thank you for being such nice company, Dr. Gbenga Alabi, and of course, Ganiu Jamiu, who couldn't join us after the break again. Both of you, I think, have done pretty well on this. But again, listening to both of you, we have come to the conclusion that medical tourism, honestly, is big business and a big necessity that Africa must also key into, as we've seen South Africa doing at the moment. So as the rest of the world grow and show what they own, it's high time this continent rose to the challenge of driving growth and prosperity. Once again, thank you for watching, and I'll see you again tomorrow.